Welcome back, and we're continuing our discussion with the antipsychotics. So, before we start our discussion, I also like to start with a big picture. I didn't really put a slide for this because the concept is really simple. The whole point of schizophrenia is that there's an increased levels of dopamine in the synapses, and all what we're trying to do with these antipsychotics is to block the dopamine uh, receptors. So you'll see with the antipsychotics, with the typicals and the atypicals, is that we're trying to block dopamine. So antipsychotics are divided into two big classes: the typical antipsychotics and the atypical. And the differentiation between these is really side effects. When they first came up with the typical antipsychotics, they had a lot of side effects because they were not clean drugs. They were not specifically targeting the dopamine. They kind of came up with these drugs and they didn't really know how it worked. But now, when they knew that the main effect is due to dopamine blockade, they came up with the atypical antipsychotics that are specifically targeting the dopamine. So our first slide, or our first discussion, is with the typical antipsychotics. And the mechanism of action is that they block the dopamine 2 receptors, mainly in the frontal lobe and the limbic system, but they also block it in the basal ganglia, and that's why you have a lot of basal ganglia side effects from these typical antipsychotics. Um, they're used as a second line for schizophrenia after atypicals, again because of the side effects. Um, the the dopamine side effects and the anticholinergic side effects are really related to potency. How potent or how strong that medication is. If the medication is very strong, so if you need if you need low doses, then you'll have dopamine side effects. If the medication is not very strong and you need high doses, then you'll get anticholinergic side effects because you'll have to hit more receptors. I sort of distributed or classified the side effects into side effects that are based on the receptor. So, what receptor is blocked and what side effect you'll get from blocking that receptor, because I think it's a little bit easier to understand. When you have D2 blockade, you'll get a lot of motor side effects because, again, you're blocking the D2 receptors in the basal ganglia. And the biggest motor side effects is uh, extrapyramidal side effects and tardive dyskinesia. And I have a whole slide dedicated for that. You also get prolactinemia from D2 blockade because remember that in the pituitary, the the pituitary gland. I forgot if it was the anterior or the posterior. Please forgive me. But dopamine is an inhibitory neurotransmitter on prolactin. So if you have dopamine, you're gonna inhibit prolactin release. If you block dopamine, then you'll get prolactin release. So a lot of these patients will complain of some nipple discharge because of prolactinemia. And the last side effect that is related to dopamine blockade is a syndrome called neuroleptic malignant syndrome. I want you to bury that in the back of your mind, neuroleptic malignant syndrome, until we discuss it in a few slides. So that's side effects that's related to dopamine blockades. Side effects that are related to anticholinergic blockades is that they cause dry mouth, constipation, urinary retention, and mydriasis. Again, all of the anticholinergic side effects that you're aware of. They also cause alpha blockade. So alpha blockade causes orthostasis and impotence. Orthostasis because you block the alpha 1 receptor in the periphery, so you'll get hypotension. And impotence is because they block the alpha receptor uh, in the um, uh, in the penis, so you get impotence. Histamine blockade causes sedation, and they also block dopamine and serotonin, which causes an antiemetic effect. And that's actually used as a some of these earlier antipsychotics are used as antiemetics. Just a little background. Let me back trace for a moment. Serotonin and dopamine are responsible for sort of the emesis or the nausea feeling that you get. So if you block these receptors, you get an antiemetic side effects. And lastly, you get prolongation of QT interval from some of these antipsychotics. So to review, you get dopamine blockades, motor side effects, prolactinemia, and NMS, anticholinergic, alpha blockade, histamine blockade, dopamine and serotonin blockade, and prolongation of QT. So as you see, these medications have a lot of side effects. Now, specifically, with the typical antipsychotics, as I've said, it depends on how potent you are, how potent the antipsychotics are. So they're divided into two subclasses: the low potency antipsychotics and high potency. What does that mean? Low potency antipsychotics, that means that you need a big dose to achieve the desired effect um, of the medication. So if you need a big dose, that means that you're going to start losing the selectivity of the dopamine. That means that you're going to hit a lot of the other receptors, the cholinergic, the alpha, the histamine. Um, all of these receptors. So example of the low potency typical antipsychotics is chlorpromazine. So it blocks dopamine, but also blocks alpha 1, histamine, and muscarinic. So you get more anticholinergic symptoms. And if they'll ask you a question on the block exam, it will be um, which medication has more anti-muscarinic side effects, and the answer will be the low potency or the example chlorpromazine. High potency example is haloperidol. That mostly blocks the D2. It doesn't have a lot of anticholinergic side effects because it's highly potent and you need smaller doses, but you get the trade-off is that you get more extrapyramidal side effects because of the blockade of T2. So as I have said, um, antipsychotics or the typical antipsychotics, they cause extrapyramidal side effects. And what is the reason for that? The reason is because there's decreased dopamine in the basal ganglia. The timeline of the extrapyramidal side effects is can be classified into hours to days, days to months, and months to years. Hours to days, you get dystonia. And dystonia is just continuous spasms and muscle contraction. Days to month, you get this akathisia, which is mainly motor restlessness, and you also get bradykinesia, which is slowness of movement. And you advance to months to years with the most feared complication, which is tardive dyskinesia, mainly orofacial chorea, which is they get these like lip smacking, and it's more like Parkinson type symptoms. Out of all of these, tardive dyskinesia is the most feared complication, and it's not reversible. Now, if you have a patient that is getting these extrapyramidal side effects, what are you going to do for them? Or what is the treatment? So the treatment is a medication called benzotropine. And I'm not sure if we've gone through benzotropine before, but benzotropine is an anticholinergic medication. And the reason that you use an anticholinergic medication is because if you remember from your neuroscience in M1 year, acetylcholine is an inhibitory neurotransmitter in the basal ganglia. So it inhibits movement. So if you have a medication that is blocking the acetylcholine, then you can have more excitatory movement. So you can treat the tardive dyskinesia and the acute dystonia. Um, Benzodiazepines and beta blockers are used for akathisia, but what I really want you to remember is benzotropine is used for tardive dyskinesia and acute dystonia. Can you tell me what other anticholinergic can be used for acute dystonia? and it's one that's really common, and we use it for if we have allergies or if we want to go to sleep at night. Benadryl or diphenhydramine. Diphenhydramine can also be used for acute dystonia and tardive dyskinesia because it's also anticholinergic. So that is the first kind of big side effects for the typical antipsychotics. The second big side effects is the anticholinergic side effects. I'm not going to spend too much time on it, but as a review, I think of these as, kind of just being dry. Um, Constipation, decreased sweating, dry mouth or urinary retention, and you also get blurry vision. So it's very important for you to understand the anticholinergic side effects. So with the advent of these typical antipsychotics, they started knowing how they work, and they started developing specific dopamine receptors and serotonin receptors that these medications bind to. And to be honest, we don't really know how exactly they work, but we know that they antagonize specific dopamine receptors. These antipsychotics, or the atypical antipsychotics, they're used as first line for schizophrenia, um, and we'll go through the specific medications. The side effect for it, what I really want you to know is metabolic syndrome. So what do I mean by metabolic syndrome? So these medications cause weight gain, hyperglycemia, and hyperlipidemia. So the test question will be, uh, a patient was started on ziprasidone, for example, or olanzapine, and what is one important test that you want to do for follow-up? And the answer should have either a blood sugar test to test for hyperglycemia or blood cholesterol to test for cholesterol, but mainly the hyperglycemia. That's what I would be worried about the most. Um, the atypical antipsychotics have much less anticholinergic side effects and much less extrapyramidal side effects. Specifically, let's talk about the specific medications with the atypical antipsychotics. The first medication is aripiprazole, and I've told you earlier that all of these medication work by blocking dopamine receptors. Well, I'm going to contradict myself and tell you of an exception here. Aripiprazole is the only medication that is a partial agonist in this class. So it's a partial agonist for D2 and 5-HT1 receptor. And do you guys understand how partial agonists work? Okay, let me explain it to you. Partial agonist is mainly a medication that kind of comes, but is sort of, a hesitant medication. It comes, but it doesn't, it comes and binds to the receptor, but it doesn't bind fully. So it half activates the receptor. So it blocks the binding of all of the natural dopamine and serotonin to the receptor, but it half stimulates the receptor. But it works. So that's aripiprazole. Second medication is clozapine, and clozapine is very, very, very important to know because there is one very high yield, actually two high yield points for clozapine. It works by blocking dopamine and serotonin receptors. I don't want you to know the specific numbers, but it is the most effective antipsychotic. So if patients fail typical and atypical antipsychotics, the treatment for resistant schizophrenia is clozapine. Now, why can't we use it first line? Why? I mean, if you tell me that it's very effective, why can't we just use it uh, first line? And the reason for that, it has a very serious side effect, which is agranulocytosis. Agranulocytosis, that means that the granulocytes, which is the white blood, the neutrophils mainly, they do not form. And I don't really know what is the mechanism for that, but you get agranulocytosis from clozapine. So that is why you need a frequent CBC monitoring for it. And that is a classic step one question. I guarantee you'll see it somewhere on your test, whether it's step one or somewhere on your block. Clozapine also lowers seizure threshold, but this is not as of a high yield point as the agranulocytosis, and that it's the most effective antipsychotics. Next is olanzapine. Olanzapine is very effective for negative symptoms. Side effects is weight gain and metabolic syndrome. It's really the worst medication for metabolic syndrome. Risperidone is a D2 antagonist. Again, side effects is you get extrapyramidal side effects and prolactinemia. And lastly, you have ziprasidone, and I don't really have much to say about ziprasidone. Now, um, so I talked earlier in the antidepressant section about serotonin syndrome, and I talked uh, in the antipsychotic section about neuroleptic malignant syndrome, and I really want to make you differentiate between both of these syndrome because they will try to trick you on the exam of which is which. So let's first start with neuroleptic malignant syndrome. So from the name neuroleptic, it's because you're using a neuroleptic medication. Malignant is because you get a lot of malignant symptoms, which are very dangerous, and syndrome because there's a lot of components to it. The cause for neuroleptic malignant syndrome is really too little dopamine. It is thought that if you have too little dopamine, you are going to stimulate the adrenergic nervous system, which is sympathetic nervous system, and you get a lot of the symptoms for it. The time is within days to weeks, and the cause is really any antipsychotics that block dopamine. When I think of neuroleptic malignant syndrome, I really think of muscles that are being rigid. So if you think of it, too little dopamine that stimulates the hyperadrenergic symptoms, I think of it as going after the muscle and attacking the muscle, making the muscles rigid. So the biggest symptom for it is muscle rigidity. Now, as a um, consequence of muscle rigidity, you're going to get elevated muscle enzymes. So if you measure the myoglobin and the creatine phosphokinase, the CPK, you'll find that they're elevated in neuroleptic malignant syndrome. You also get hypertension and tachycardia because of the hyperadrenergic response, and you'll also get fever. Now, what is the treatment for neuroleptic malignant syndrome? The treatment is two things. The first thing is that you want to relax these muscles. And how you relax these muscles is a medication called dantrolene. So I think we'll talk about dantrolene a little bit later, but dantrolene um, is a very sophisticated medication. If you think about how muscles contract, so muscles contract by release of calcium from the sarcoplasmic reticulum, right? So dantrolene comes and blocks the sarcoplasmic reticulum and blocks calcium release, so it causes muscle relaxation. So that is the first medication that you use for neuroleptic malignant syndrome. The second medication that you use is that you use a dopamine agonist, which is bromocriptine. So we know that neuroleptic malignant syndrome is because they have too little dopamine, so you can use a dopamine agonist, which is bromocriptine. Very, very important to understand neuroleptic malignant syndrome. So these are with the antipsychotics. Now, the next syndrome that we're going to talk about that is kind of similar is serotonin syndrome. And serotonin syndrome is because there is too much serotonin. It's typically within 24 hours of starting medications that increase serotonin, and it's really caused by any medication that increase serotonin, mainly the antidepressants, so the monoamine oxidase inhibitors, the SSRIs, the SNRIs, the tricyclic antidepressants. But also there are other medications that are not antidepressants that increase serotonin. So tramadol, we're going to talk about it in the future. It's an opioid. It's a synthetic opioid that increases serotonin. Ondansetron, which is an anti-nausea medication that increases serotonin. Triptans, which is a medication for headache that increases serotonin. And linezolid. Do you remember what linezolid is? We talked about it in the antibiotic section. So it's a protein synthesis inhibitor, and it also has a monoamine oxidase property. MDMA, which is ecstasy, increases serotonin. And lastly, dextromethorphan, like the cough medicine that we buy over the counter, that can also increase serotonin. So really, any medication that increases serotonin can cause serotonin symptoms. When I think of serotonin syndrome, I think of like something neurologic. So it kind of helps me figure out the symptoms. So the symptoms for it is hyperreflexia. So you have a patient that's hyperreflexic, and you also get some dilated pupils with the serotonin syndrome. You also get diaphoresis and diarrhea. Diarrhea because you have too much serotonin, and diaphoresis is also because serotonin causes diaphoresis, and you also get agitation. So think of neuroleptic malignant syndrome as muscles. Think of serotonin as nerves, mainly hyperreflexia and agitation. The treatment for serotonin syndrome is that you give them, you know that they have too much serotonin, so you give them a serotonin antagonist, which is cyproheptadine. Do you guys know um, what use or what is actually cyproheptadine? So cyproheptadine is actually an antihistamine. It's I believe a first generation antihistamine, but they found that it has serotonin antagonist properties, so they started using it for serotonin syndrome. Um, so lastly, I wanted to talk about summary for schizophrenia and where do we sort of use these medications. So if you have a patient with positive symptoms, first line is atypical antipsychotics, second line is typical antipsychotics, and third line is clozapine, and we talked about why it's third line. Negative symptoms, um, clozapine is very effective and olanzapine is also very effective. So that ends up our discussion with the antipsychotics. I put in a few questions for your learning, but that's about it. If you have any questions about antidepressants or antipsychotics or any questions in general, please feel free to email us, me or Mike. And I hope that everything goes well for your exam and hope you have a blessed break. Thank you very much.